Good evening, friends. Uh, Respected office bearers of IPNRC, dear delegates who have joined today evening for this advanced pediatric pulmonology clinic, a warm welcome to all of you. I hope you are enjoying these clinics and learning the intricacies, how to work up, how to uh, solve a puzzle, clinical puzzle in pediatric pulmonology. Today we have a case from Shishuka Children's Hospital, Bangalore, and Dr. Priyadarshini would be presenting the case, and the mentor is Dr. Bharat Reddy, and the experts for today's session are Dr. Sanjay Bapna from Pune and Dr. Ankit Parak from Delhi. Both are seasoned and experienced pediatric pulmonologists, and we hope that they'll guide us how to work up this case. And the moderator, as usual, is Dr. Kamal Singhal, again the veteran person who has been guiding this clinics for past 2-3 years, and he has done a great service to IPNRC for this particular program, and we are really thankful to him. So, sir, let the ball roll, and I'll request Dr. Kamal Singhal to start the presentation.
Thank you, sir, for the kind words. I'll straight away request Dr. Priyadarshini to start with the presentation.
Good evening, everyone. So I am Dr. Priyadarshini. I am doing my fellowship at Shishuka Children's Specialty Hospital, Bangalore, under the guidance of Dr. Bharat Kumar Reddy, sir. So I'll start my presentation. Sir, again, it's not changing. So we have a child, 4-year, 7-month-old child who presented to us at the age of 4 years, 3 months with the chief complaints of cough since 1 month and recurrent fever since 1 month. Our child is a known case of cystic fibrosis who was diagnosed at the age of 4 months, has now come with history of cough since 1 month, which was insidious in onset, wet type of cough, no postural or diurnal variation, and which had partly subsided with intravenous antibiotics. It was also associated with wheeze, chest retractions, and hurried breathing intermittently. There was episodes of fever on and off since 1 month. It started 1 month back for a week, high-grade intermittent type, then followed by afebrile period for 2 weeks, and again now fever recurred since 3 days. It was associated with history of poor oral intake and reduced activity since 1 day. Child is firstborn to a second-degree consanguineously married couple with uneventful antenatal period. He was born by vaginal delivery at term gestation with a birth weight of 2.5 kg, cried immediately at birth, and no significant immediate postnatal complications. The first admission was at the age of 2 months when he presented with inadequate weight gain. He had gained only 200 grams per month and associated with history of passage of oily stool since birth. He was admitted with issues of metabolic acidosis, severe hypoalbuminemia, and severe anemia, for which he received PRBC and albumin infusion. The second admission was at the age of 4.5 months when he presented with fever and cough of 4 days duration. Again presented with severe anemia and elevated CRP. He was given PRBC transfusion and started on IV antibiotic. During the ward stay, he had presented with 1 episode of generalized tonic-clonic seizures on day 4 of admission, secondary to a massive intracranial bleed in the left parieto-occipital region and subdural bleed, predominantly left side, associated with gross midline shift, necessitating emergency decompressive craniotomy and other supportive measures like anticonvulsants and transfusion. He also had aspiration pneumonia requiring higher antibiotics, meropenem and amikacin. The fourth concern was his failure to thrive, for which he was evaluated and found out to have exocrine pancreatic insufficiency by low stool elastase levels, for which he was started on creon supplement, vitamin A, D, E, and K supplementation. After, as he had presented with failure to thrive, exocrine pancreatic insufficiency, he was suspected to have cystic fibrosis, and whole exome genomic sequencing was done, and it proved homozygous mutation of CFTR gene. Subsequently, at 7 months of age, he had presented to us initially at 7 months of age with lower respiratory tract infection. So, as he had right middle lobe collapse consolidation, so we underwent, we proceeded with bronchoscopy, which showed thick purulent secretions and mucus plugs. Culture had grown Pseudomonas aeruginosa, and BAL AFP was negative. He was treated with IV meropenem for 10 days, tobramycin nebulization, and initiated on the respiratory therapy for cystic fibrosis. So he was started on budesonide, MDI 100 microgram, 1 puff twice daily, 3% saline nebulization, chest physiotherapy, and apart from that, the nutritional supplements were continued. So this shows us, so right from second month, because of the poor weight gain, then he presented with vitamin K deficiency, and our genetic test proved cystic fibrosis with the first exacerbation at 5 months of age. From age 1 year to 2 year, he was lost for follow-up, and he was followed up in another hospital, requiring 2 admissions with pneumonia, treated with IV ceftriaxone. He remained compliant with inhaler and other nutritional supplements. At the age 2 year, 8 months to 3 years, he was compliant and there were no exacerbations. At the age of 3 years, he had one more exacerbation, treated with IV piperacillin and tazobactam for 14 days, and tobramycin for 1 month. After 6 months, because of the persistent opacities in the right upper zone and right mid zone, he underwent bronchoscopy, which showed growth of Staphylococcus aureus sensitive to oxacillin, clindamycin, and linezolid. He was treated with oral linezolid for 14 days. Cardiac evaluation was normal. So he had, apart from these admissions, he had exacerbations necessitating gentamicin and tobramycin nebulization. So in the first year, he required twice. Then second year, he required twice. And so all these, whenever it depicts the time of exacerbation. Immunization history is appropriate for age. Developmental history, mild global developmental delay with predominant speech delay was seen. Dietic history, his deficit in calories by 400 kilocalories and proteins 8 grams. Environmental history, nothing significant, resides in a pakka house with adequate ventilation, and there is no exposure to pigeons, construction dust. So to summarize our case, 4-year, 4-month-old child who is a known case of cystic fibrosis came with symptoms of persistent wet cough with wheeze since 1 month and recurrent fever since 1 month. So this suggestive of persistent pneumonia in this child.
Thank you, Dr. Pridarshini. I think let us hold on here.
Yes.
We have a lot of things which have come in, different from the usual presentation that we have, because we upfront have the diagnosis. We upfront have a lot of investigations, what years of age, and diagnosed with cystic fibrosis, genetically proven very early on. But he has had 2-3 things in this. So first, with the lead discussants, I have some questions lined up in the chat box that I'll ask later. But first, with the lead discussants, if you wish to seek any clarification, or you wish to comment on the history till now, Dr. Sanjay Bafna, sir.
Thank you, Kamal. I'm audible, right? Hello?
Yes, sir, you are audible.
Yes, sir. Yes,
Okay.
sir,
Yes, sir, you are audible.
Right. So we have this child who is actually diagnosed at 4 months of age with cystic fibrosis and had probably late HDN requiring craniotomy. And then, of course, he had multiple exacerbations, and then he was put on probably nebulizations and chest physiotherapy. The present problem seems to be fever, which is persistent, and probably the pneumonia, which is persistent. I want to know from Dr. Priyadarshini, for
Yes.
this first 7 days, I think he had fever and then he became afebrile. So what was the treatment received? Was it in your hospital or outside hospital? What
Yes,
was
sir.
the
So he
antibiotic?
was. Okay. So first, sir, 1 month back, he had presented to us with fever of 7 days duration and cough, and with respiratory distress. So we had hospitalized him and we had started him on injection meropenem, and we had continued with the other supportive measures like nebulization. After 48 to 72 hours, so sorry, just a second. I'll just hand over. Just 1 second, sir. Sorry for disturbance. Give it to stand up. Sir, sorry. Then we had discharged him on tobramycin nebulization and continued IV antibiotic for 14 days. Then after stopping the IV antibiotic, only for 1 week, the cough had slightly reduced, but wheezing was persistent. And once we, after that, again, he started developing fever and cough. And we had we had compared, one is the clinical condition, the wheeze was still persistent. And the X-ray also showed the same opacities. So that's why we further had to evaluate him, because he was not, even in spite of giving the IV antibiotic, he was not responding afterwards.
So in that case, you had given meropenem and on discharge, you started him on tobramycin nebulization and he came back with fever and persistent cough and wheezing. So what
Yes.
is your thought process? Like the child with cystic fibrosis with
Ah.
a persistent pneumonia, what thought process do you have now?
Sorry, sir, what?
What is your thought process now? Why his fever is persistent or is recurrent again?
Okay. Sir, one
We'll
is
go to the X-ray and investigations later. But at this
okay.
stage, what do you think the child with cystic fibrosis, what is the reason for persistent pneumonia?
Okay. Sir, one is related to the host factor. The other one is the related to the infection causing factor. So if we are dealing with a bug which is not responding to this particular antibiotic, so that is one thing. Or secondly, is the child having other conditions, like for mainly in cystic fibrosis, we consider when there is no response or persistent wheezing, the second thought that comes to our mind is allergic bronchopulmonary aspergillosis. So,
Okay.
and the third thing is, if it is inadequate, oh no, sir, these two are the main things.
And what about microbiology? You said bacterial infection. Do you consider any other infections in a child who was hospitalized, received antibiotics, broad spectrum antibiotics, then came back to you with fever in a child who has cystic fibrosis? Do you consider any other microbiological problems?
Other fungal infections.
Okay. And any other particular organisms which we are worried?
So other, okay.
Okay, we'll go to the investigations later. This is all from my side, Kamal. I think you can carry on.
Thank you, sir. Thank
Maybe,
you so much,
yeah,
sir. So, Dr.
yeah.
Priyadarshini, what the Dr. Bafna is trying to say is that you have a child known case of cystic fibrosis he comes to you, he doesn't seem to be responding to the antibiotics that you're giving. So what are the possibilities that you would think of in a child who is not responding? So that's how, so infection is a part of it. Now I'll bring in Dr. Ankit Parakh. So Dr. Ankit, your take on this.
So I think in addition to what Dr. Bhafna sir has said, would you keep a possibility of tuberculosis in mind?
Yes, yes, exactly. NTB and tuberculosis.
ABPA is not very common in under 5 children, even in CF. Although there is nothing which prevents a fungal infection. It can happen, but it's not very common at that age group. So that is one possibility. And are you looking at any other cause of fever, or do you think it is only related to the chest?
So in him, sir, only related to the chest.
Okay. Okay, fine. Let's go on.
So thank you, Dr. Ankit. So Dr. Pridarshini,
Yes, sir.
I have something lined up in the child at 4 months presented to us with some kind of a bleed.
Sir, sorry, some kind of
He had a bleeding,
bleeding.
intracranial bleed. So do you think it was preventable when he was admitted at 2 months of age? Did we miss out something? Something that could have been done, which was not done? Was it preventable? Child at 4 months and 19 days had an episode of seizure and you found massive intracranial bleeding. Hello, am I audible?
Yes, sir. Yes, sir.
So at 4 months and 19 days, he had a massive intracranial bleeding. Do you think at something could have been done prior to that? I mean, at 2 months of age, with this kind of a syndrome, a child who is
Not
failing to thrive, who has oily stools, who has metabolic acidosis, hypolipidemia, all this probably very early somebody could have picked it up. And if suppose this is probably the vitamin K deficiency is what led to this catastrophic presentation,
Yes.
which otherwise. So at this 2 months of age, was possibility of CF considered?
At 2 months of age, no, sir. Only
Okay,
later.
because the thought process of the treating team at that time is very important, because this is the time when he had a lot of things which would make CF very likely in such a child.
Okay. Failure to thrive.
So okay, and if suppose the at least considering a suspected cystic fibrosis, if at least supplements were started, probably he would not landed up with that kind of a presentation that we have. So the question in chat box is, why do you think the child had bleed? Is there any other explanation for that? Okay, one we said vitamin D deficiency, because he CF, fat soluble vitamins will be a problem here, and he has not been supplemented and it has not been given. So that's a stage for somebody to have a bleed. Any other possibility that you can think of? And why did he have acidosis?
Wow.
Okay, I think it is very early on in the presentation, but the one possibility could be that the child, when he presented, maybe he had a severe septicemia or something other than that. So usually in cystic fibrosis, it is alkalosis metabolic, but when somebody has a superadded septicemia infection, at that time all that may be masked. That the classical alkalosis and all will unmask only when you have treated these acute complications. So maybe that could be one of the reasons. Otherwise, any antibiotic prophylaxis, you have talked a lot about what antibiotics were given. Was he on some kind of an antibiotic prophylaxis also?
No, sir. He was not on antibiotic prophylaxis.
So even after diagnosis of CF, did we consider some kind of a prophylaxis,
No,
or
sir.
as a policy do we give?
No, sir. He was not given.
Okay. And there is one more question in the chat box: middle lobe syndrome. This is because your child had a middle lobe involvement. Any take your take? Are you aware what is a middle lobe syndrome?
Yes, sir. So there will be like whenever there is localized lesion affecting the middle lobe, so uh, uh, that could lead to like bronchiectasis of only the right middle lobe.
Okay, so it is primarily the right middle lobe involvement, because it's a longish kind of a lobe, which the position is such that it is predisposed to all kind of obstruction. So if you have a lymph node, the right middle lobe will be primarily affected. In our country, TB is something that can cause it. But any compression, intraluminal or extraluminal compression can cause it. So this is, I think, all pneumocystis carinii. Would you consider a possibility of pneumocystis carinii in this patient?
Unlikely, sir.
Okay. One thing is very stark, that till almost 2 years and 8 months, the child was not growing at all, not growing well, and then suddenly he shot up. Thereafter, from 8.5 to he became 12.8 kgs. So what happened in this phase,
Yes, sir.
which was not happening earlier?
Sir, I'll just in the growth chart I've just mentioned, so I can explain that in better in the growth chart.
Okay, fine. Let us move on then.
Just one question to Dr. Priyadarshini
Yes, sir.
before we move on.
Ah.
What would be your choice of antibiotics when the patient of known CF had grown Pseudomonas once, had grown staph once, has landed with exacerbation and persistent fever for 7 days in the initial phase I'm talking. So what would be your thought process and what would be your choice of antibiotics? Was it appropriate? Do you think anything else could have been added, or it was appropriate? You started with meropenem right away. Blood culture, supposing that you must have taken, but what would be your choice of antibiotics in exacerbation? And then we can move on.
Okay. If we are suspecting staph aureus, then we would go for linezolid.
You would go for linezolid? Dr. Ankit has already commented, no?
Okay.
And would it be a dual antibiotic empirical cover if you are suspecting Pseudomonas, or a single meropenem is fine?
Not sure, sir, not clear about
Okay.
it.
So basically, I think when you are having an exacerbation, or you're thinking that this is a CF exacerbation, the two organisms, of course, you have to cover is Pseudomonas and staph. And for Pseudomonas, if it is empirical, it is always a dual cover. So I don't know whether Tobra was started simultaneously, but otherwise you will have to give two IV antibiotics. And if it is staph, which you are considering, which is possible in a younger child, then you need to cover for staph as well. So meropenem will cover MSSA, but MRSA will be still not covered. So that would be your policy, at least two antibiotics which covers Pseudomonas and staph. Okay, I think we can move, Kamal.
Yes, sir. So the point
Yeah.
here is that unlike other infections, other persistent pneumonias, when you're looking at cystic fibrosis, you will cover both. You will cover Pseudomonas with two antibiotics, and you have to closely monitor their cultures, because when the child comes to you in a sick state, it will take time for you to have culture. So it is based on the previous cultures that you treat the next time when the patient arrives. That is one. And one set of antibiotics is to treat the acute infection that is there. Other set of inhaled antibiotics is when you are trying to reduce the bacterial load over time, and the inhaled antibiotics are not for an acute infection of a current pneumonia. It is when you have exhausted your option in terms of what you are, in terms of injected parenteral antibiotics, and then you are trying to reduce the load as much as possible, because in such children, the lungs when infected, it is very, very, very difficult to make it sterile, and it's a bad prognostic sign that the child had an MRSA so early. When he has it, the prognosis definitely goes down. So I think let us proceed with the presentation.
Yes.
On general physical examination, he was tachypnic with maintaining saturation of 90% in room air. Grade 2 clubbing was present. Anthropometry, height comes to 10th centile, 98 centimeter, weight 12.8 kg, 3rd to 10th centile. So this is his growth chart. So first at 2 months of age, when there was failure to thrive, then after at 4 months, once he was diagnosed and started on creon supplementation and vitamin supplementation, there was increase in the weight parameter. Then subsequently, 1 to 2 years, he was not on regular follow-up with us. So we are, but though he was compliant, we are not sure of the adequate treatment if he has received. Then again, from 2 to 3 years, there is constant growth seen. And again, last 2 months, so 4 year, 4 year, 3 months to 4 year, 4 months. So again, in that, because he had that 1.5 to 2 month of 1 month of acute recurrent symptoms. So again, his weight has become stagnant. Systemic examination, respiratory system, pectus carinatum seen, and Harrison's sulcus was seen with suprasternal recession and subcostal retractions. Palpation, chest circumference 55 centimeter, AP diameter 14 centimeter, transverse 18 centimeter. Percussion, resonant note was felt in all lung fields. Auscultation, bilateral V's with coarse crepitations were present. Rest of the systems, there nothing significant. Sir, can I proceed with the investigations?
Yes, please.
Okay.
So let's just have a word, Dr. Bafna. Anything that you wish to, based on this
Can you go
examination?
back, please? Can you go back, please? So, yeah, go back, please. Okay. So, this Harrison sulcus, pectus carinatum, what are they suggestive of?
So, sir, it suggests that there is early respiratory insult, wherein the child has been using the respiratory, like there has been respiratory difficulty. So, more work of muscular action. So, due to which they develop this
And then
deformities.
next slide, please. So you have subcostal and suprasternal retractions, and you have any significant finding here? This here.
We
Anything as unusual in this findings here? You are expecting infection, but anything else?
sir, the percussion note being resonant.
That's fine. What about auscultation?
Auscultation, bilateral V's.
Okay. So what does it tell you?
Oh,
Because
so
you're saying persistent cough, persistent wheezing, of course,
Yeah.
fever and crepitations are expected. So how does it help you?
Sir, one is the persistent. So, so first, what it signifies is the mucus plugging. Because of the mucus plug, not effective chest physiotherapy. So that can be the cause for the bilateral V's because of the mucus plugging. Then second thing is we'll have to think of other conditions in cystic fibrosis, that is ABPA.
Okay.
So these are
And
the thoughts, sir.
and can this child have a viral wheezing also?
Viral V's, but sir, the duration of illness, if we see it's been 1 month, so less likely viral.
But in between 2 weeks, he was afebrile, right?
No, sir. The symptoms had only reduced, but not completely asymptomatic.
Okay. Okay, fine. So I think wheezing is something which you need to, crepitations of course are expected because of bronchiectasis, fever, infections. Wheezing is something which can happen in bacterial pneumonia, but persistent wheezing, you need to think that there is some airway involvement which is more, and in cystic fibrosis, as you said, there are certain infections which may involve airway more. And secondly, of course, AVPA is something which you need to keep in mind. Yes, that's all.
Thank you, sir. So what sir is trying to
Yeah.
say is that when you have a child who, despite appropriate antibiotics, is having persistent respiratory distress. So one is infections. You go beyond usual bacterial infections. Think of things like TB and all. Even a viral infection in such patients, because the virus induces a transient kind of a ciliopathy, and because it further reduces that ciliary movement, they are known to have these exacerbations. So viral can be one. Secondly, it could be non-infective causes. Patient may be landing up in corpus banale, and the distress is not because he's not going to respond to antibiotics. So of course you would think of things like pneumothorax and all those things, but that is very difficult to miss if you have a radiograph and all. But corpus pulmonale is something which is missed. The patient had distress because of corpus pulmonale and was kept on getting antibiotics. And as far as wheeze is concerned, in cystic fibrosis, a wheeze may indicate a fresh bacterial infection in cystic
Yes.
fibrosis.
Yes.
Dr. Ankit.
Yeah, I think I agree with all these things. So, what everyone is trying to say is that are you looking at a parenchymal lesion or are you looking at an airway disease, right? And in addition to what has been said, there can be some viruses which can lead to prolonged fever and wheezing, which is persisting. And adenovirus is one which can be, causing such illness. So I think to summarize, we should think in terms of an infection which has not been dealt with properly with the current antibiotics. So that's one. Second, you should keep a possibility of an aspergillus tracheobronchitis. Okay, so we're not saying ABPA. Okay, ABPA is not a tracheobronchitis. ABPA is an allergic reaction, but a lot of children with cystic fibrosis tend to have aspergillus, which grows from the airway. We have seen a few being there. So that should be kept as a possibility. You should keep a possibility of tuberculosis. You should keep a possibility of an NTM. You should also keep possibility of atypical infection. So sometimes when you do a bronchoscopy, you find multiple things coming up. For example, things like Burkholderia and all these things, right? So these things should be kept, and I think viral infections like adenoviral can also present like these things. Yeah, so I think please go on.
Yes, Dr. Priyadashini, please move.
Yes. Coming to investigation, there was leukocytosis with neutrophilic predominance and slightly elevated CRP. So the left side X-ray was the first X-ray when the child presented 1 month back. So it shows non-homogeneous opacities in the right upper zone. And this was the X-ray after 1 month. So the opacities are being persistent. So we at admission.
Just one question here. Sorry to interrupt. Just one
Yes.
question. Can you go back to the X-rays?
Huh.
So in both these X-rays, you find that the left lung is a bit hyperinflated as compared to the right, and there's some shifting of the cardiac salute to the right side. So, do you think there can be a possibility of a foreign body aspiration?
Clinically, sir, there was no difference in the breath sounds. Then the other thing that explained to be the right side lung pathology is the lung pathology is very severe. So there is compensatory hyperinflation on the left side.
There doesn't seem to be any collapse. There's some patchy infiltrates everywhere. There is no real collapse of the right side. So either if we are saying a lobar collapse, which leads to a volume loss, that doesn't seem to be there. So even if we are not able to explain this at the moment, but there is some difference in the aeration of the lungs. And there is a definite shift of the cardiac silhouette towards the right side. And there is some hyperinflation of the left side. Okay.
So in these patients, if had it not been CF and you have unilateral signs, you think of cystic foreign bodies, but here the foreign body, which means intraluminal obstruction, the cause here would be a plug.
Mucus.
Then
Mucus.
actually something coming from outside. It will be a plug which can create problems in cystic fibrosis. Yes, please move on.
So we had initiated with intravenous piperacillin tazobactam and inhaled tobramycin along with airway clearance measures with chest physiotherapy. Because of the persistent symptoms, we went ahead with the bronchoscopy. So it revealed mild tracheomalacia and thick, viscid, purulent secretions in trachea and all bronchi. And we sent lavage samples for analysis. So at discharge, we continued IV piperacillin tazobactam, tobramycin nebulization, along with saline 3% saline nebulization, anti-inflammatory and budesonide MTI with formoterol 2 puff twice daily, and pulmozyme neb along with nutritional supplements, that is crayon and vitamin A, D, E, K supplements. So the culture, we could isolate MRSA strain. It was sensitive to linezolid. So we stopped piperacillin and started on IV linezolid for the next 7 days. Because still, in spite of giving the antibiotic, child continued to have clinical symptoms and persistent V's. We wanted to evaluate further and did the HRCT thorax. So it shows multiple patchy alveolar space infiltrates noted in peribronchial distribution in apical and posterior segments of the right upper lobe with mild bronchiectatic changes, and also consolidation with air bronchogram and bronchiectasis involving both medial and lateral segments of the right middle lobe. So with this also we, because of the persistent V is not responding, so we
So,
had...
Dr. Priyadarshini, let us, can we go back to the CT?
Yes, sir.
So we do not have a mediastinal window here, na?
Sorry, sir, I didn't add. Sorry.
Okay, fine. Because, you know, which lobe do you think is involved here?
So it's the right middle lobe
Let
and
us
the
look
right
at the
upper.
axial view. They'll be above this. Axial views, the axial view.
Yeah.
Yes.
Yeah.
Yes.
Middle lobe.
So so in a middle lobe you have medial and lateral segment. So which would it be, medial or the lateral?
Both, sir, medial and lateral.
Is it
okay? Because you know, sir, Dr. Bafna, sir.
And right.
So how do you know whether it is medial or lateral? That's the question I think Kamal is trying to ask you. Is it with cardiac border or with, away from cardiac border? So is it medial segment? And before we go to CT, Did you do the investigations first and did CT or blood investigation like IG or ABP workup was done before, or after CT you went ahead and did it?
No, sir, it was like along with the bronchoscopy. During that time only, we did even the blood investigations.
Okay. So which segment? Do you think medial segment is more likely in this child or both segments? And of course, there is generalized involvement. Medial segment is more affected, but I think there is ground glassing of the whole upper lobe also as well also. And I think there are infiltrates bilaterally. So there is a diffuse disease, I would say, with more involvement of the medial lobe and medial segment more likely. And again, about antibiotic choice. I mean, the patient got admitted second time. Why was MRSA not added in the first place itself? I think we had that discussion before also. So if you had started him on piperacillin tazobactam, when patient is admitted, it is always two Pseudomonas IV antibiotics. On an OPD basis, you can give quinolone and tobramycin, that's fine. But an admitted patient will receive two IV antibiotics for Pseudomonas, and MRSA I would give because this child is not responding. So before even BAL comes, I would have started him on some MRSA antibiotic.
Okay, so in addition to your bacterial cultures, did you grow something on the fungal cultures, and did you get an
Staining.
expert? Did you get any atypical organisms, or all that was negative?
Yes, sir. So we also got in NTM PCR was positive, sir.
Yeah.
And we had also sent the AFB culture, and subsequently we could isolate the species identified was Mycobacterium abscessus.
Yeah. So, and what about gene expert? The expert was negative.
Yes, sir.
And what about how would you differentiate? You want to know on the staining basis, expert would be negative in NTB or positive?
Sorry, sir. Sorry.
Your gene expert,
Ah.
would it be positive in NTB or negative?
Gene expert, it will be negative.
And then how do you know what would happen on Zn stain?
Zn stain might be positive, sir.
Okay. So this was NTB.
Okay.
And even the ABPA workup, total serum IG was elevated, and Aspergillus fumigator specific IG was positive. With with all these reports, now next we were in a situation whether to treat what treatment to be started first and how to address. So we did take the help of infectious disease specialist. So because she had suggested to start on oral oriconazole for ABPA to withhold steroids, and to repeat CT after 4 weeks. So if there is worsening, or if there in the CT, or if there was clinical worsening unexplained by other cause, she had suggested to treat the present mycobacterium. So hence we started him on oriconazole 6 mg per kg on day 1, followed by 4 mg per kg twice daily. After 4 weeks of oriconazole, he had no fever or cough. Though there was weight loss of 600 grams, clinically respiratory system there was no wheeze. And along with oriconazole, we had continued other supportive treatment, and child was compliant with the therapy. After 4 weeks, so total 8 weeks of voriconazole, we repeated the CT, and we didn't find any worsening radiologically, as well as we didn't find any clinical worsening. So we took a review from the infectious disease specialist, and she had considered to start oral steroids and to continue oriconazole. So currently, child's weight is 12.7 kg, has gained 600 grams. Clinically, there is no V's, and he's currently on syrup oriconazole 4 mg per kg twice daily, MDI budesonide with formoterol, chest physiotherapy, crayon, and vitamin supplementation. So our final diagnosis is cystic fibrosis with ABPA, but still other concern was regarding the non-tuberculous mycobacteria.
Okay, Dr. Pidarshini, I think you have done a good job, presented the case well, but there are a lot of things which are contentious here. So I think you are ending your presentation by posing a
Yes.
question: when should we
Yes.
treat Mycobacterium abscesses? So we will straight away begin with you itself. What would you do in this scenario, or what is your plan? And then I'll bring on the lead discussants.
Okay. So, sir,
So
because
according to you have, because nobody knows more about this patient than you here. So what is your take that given all this scenario, would you treat this child for Mycobacterium abscesses or no?
okay. So there are few points for and few points against. If we come to the criteria for treating, so if we consider the clinical criteria, the symptoms which were not responding to the usual antibiotic, but however the CT didn't show such nodular lesions. And we have we had other diagnosis, that is ABPA, and microbiologically we had one positive culture, so we had 2 points for and 1 point against. So I'm not sure, sir, whether to treat or not to treat.
So let us look at these three things. You need three things, at least two out of three things when you are about to treat such patients. One is clinically. Do you think the patient has clinically deteriorated or improved?
Clinically improved, sir.
Okay, that is one when you say the patient is clinical. But this time we presented to you with fever, cough, and everything going on for 1 month.
Sir, just so they had so all this was he had presented 2 months back. So after
Okay,
we
fine.
started voriconazole, they have followed up now. So it's been 2 months of voriconazole. So the latest CT is done. The second CT which I showed, sir, that is recently, just a week back.
Radiology, is it the same or is it worsening? There is a worsening. I mean, new cavities, new nodules, worsening
It
bronchiectasis.
is the same, sir. We felt it's the
It is the
same.
same.
So, and clinically,
Thirdly,
he didn't have any further V's or
how
cough.
many
Sorry, sir.
cultures? How many cultures are positive?
Only one, but it's one BAL sample is positive.
Yes, it is BAL. So for
BAL.
BAL, even one
So,
culture is significant.
yes.
But you will always have a problem uh, treating this condition for an asymptomatic thing. Clinically is not worsening. Both are not showing any worsening. Very difficult to treat such patients. Anything in this case that you think um, should be done or could have been done to improve the outcome? Let us just move away from that simple one question. You have seen the patient overall. So what would you have done differently in this patient? Dr. Bafna, sir.
Okay, so the patient, as we have already discussed, got admitted and then discharged and then came back. Now, when the patient comes back, I think cystic fibrosis, as we have, just to recapitulate, we have to think of beyond routine bacterial infections. Pseudomonas and staph, of course, remains at the back of our mind, but you have atypical infections like because they are in the community. So it's not that cystic fibrosis will not have mycoplasma or other atypical infections. Tuberculosis is always in our country, and NTM is one organism which is first known to have caused exacerbations in cystic fibrosis. So infections, and of course fungal viruses and all that we have already spoken. Second possibility, always ABPA you need to keep, and fever of infection at other side, other infections, thrombophlebitis, all this comes. When the patient landed with us, if I was a treating physician, I think I would have covered him with Pseudomonas with 2 IV antibiotics and MRSA cover. Now that I know that the patient has not responded to whatever I had given initially, and then of course go all out and try to find the bug, which they did by doing a bronchoscopy, by all the cultures. I would do fungal staining also, fungal culture also, and of course complete workup of ABPA. So that includes your IgE, IG specific for this, IgG for even aspergillus, eosinophilia, look for eosinophilia, and CT scan. So all this, some of them were done, but upfront I would have thought of this, and before even going for CT, I would have done that, and the antibiotics choice would be different. Now coming to the question of this NTM, now and ABPA, the CF is known to have polymicrobial infection. So we have to keep this in mind. So you grew something like staph, and then you also grew NTM. So it is possible in CF because you have polymicrobial infection. In fact, you have different species of Pseudomonas growing in the CF patients from different lobes. So this possibility we have to keep in mind, that they can have 2 bugs growing, and they both can be responsible for infection, and we can't take chance in a patient who has a comorbidity. So we need to treat. Now coming to treatment part, at that point of time, giving itraconazole or voriconazole, both are same, and we would treat ABPA. But I think if given that the ball grew NTM, there was a clinical features which the child was not improving. There was a radiological feature showing some bronchiectasis. I would have started him on NTM therapy, because I don't know what will happen after 1 month. I would not have waited and given him 3 to 6 months of, because it's a short course. It's not that routine 6 months course, so 3 weeks. Now, another point is we have given him meropenem for 14 days. We have given him linezolid. So many of these are anti-tuberculous drugs. So we don't know, because then we end up treating them partially. So this is the problem with meropenem, linezolid. All these are AKT drugs. Actually, meropenem is a reserve drug for tuberculosis. So that's the problem. So I would treat this patient for NTM also. And then because I'm not sure whether I should not be missing that. And then again, NTM is something which is a very slow growing, slowly progressive disease. So it can be there, and then you can land into trouble.
Thank you, Dr. Sanjay sir. Dr. Ankit, what would you have?
And one point, a lot of pointers, like one important point is most of these patients do not need, of course, this child had wheeze, and you have a reason for wheezing. So giving formoterol, giving budesonide for long period of time is not recommended in these patients. So I think that is one important point we need to remember in mind. This was a 5-year-old or 4.5-year-old child. Okay.
Dr. Ankit.
Yeah, so I think it is a difficult situation, right? And there are no very good answers, or you don't have, one best answer. So I think the way you did was, it seems to be reasonable to me. What I would do is, keep this child under surveillance, make sure the MRSA is well treated, because a lot of patients with MRSA, they keep harboring the MRSA, and the infections come back and back again. And in some of these patients, you might have to continue linezolid for a longer time. Sometimes you do it monthly, stop it, and then do. So good surveillance culture might be one. Bronchoscopy again is one way to look at MRSs, because MRSA can bring the lung function down quite rapidly. Treatment for ABPA, well, is absolutely well warranted. We know that you added steroid after a month, that was fair enough. You treat it like a first episode ABPA and keep monitoring with serial X-rays and IgEs. That's the way out to it. Now, regarding the NTM, the problem is that, the abscesses is not very easy to treat. And if you read treatment for abscesses, and we had a few of them, there has to be one parenteral antibiotic. You cannot do without that if you read the IDSA guidelines. And so you have to include something which is IV, and that makes it very difficult. So treating abscesses is a big task. Keeping this child under surveillance with microbiology, if the child can produce and induce sputum, and radiology, would be fair enough. Although no one is right or wrong, you might find that gradually after a few years the bronchiectasis worsens, and then you realize it is the abscesses which has been a problem. So clear one bug, keep looking for the next one. If everything remains stable, it can just be a colonizer which can be there with CF. But treating abscesses is not as easy, especially in children who are on multiple drugs. But as I said, I don't think anyone has the best answer here.
Thank you, Dr. Ankit. And at this point, I would thank and congratulate Dr. Priyadarshini for an excellent presentation. There has been a lot of grilling, a lot of questioning. So the idea is it's a learning for the presenter as well as the present team here. And now I'll bring in Dr. Bharat Reddy, the mentor, on why he chose this particular case, and if there are anything specific that or whatever he wants to share. Dr. Bharat
Stop
Reddy.
sharing, Dr. Priyadarshini. You can stop sharing, please.
Yes, sir.
Thank you, Dr. Kamal. I think one of the reasons I brought up this case was I thought we need to discuss the complexity.
Can you stop sharing, please? Yeah.
So I think one of the reasons I brought up this case was I think all the points which were discussed with respect to the management of a complex CF. I have few more questions to the moderator.
Bharat, your video is off, I think.
Actually, your audio is also a bit low,
Video,
Dr.
video,
Bharat.
video.
Video is not on.
Yeah, can you?
Yeah, is it better?
Yes,
Yes.
it's good now.
Of the reasons I brought up this primary issue was with relation to the steroid therapy now. We're supposed to start steroids for ABPA, but we're still not complete. You see, most of us are debating whether it's NTM is to be treated or not treated. So in that background, how safe is it for us to give steroids in this child?
Okay. Dr. Sanjay, I think you
I
have
would,
answered
I
in-
would treat NTM. I would treat NTM and then I would be safe.
But NTM, like Ankit mentioned, is an IV antibiotic. So giving IV
I know.
antibiotic, I don't even get IV lines in this child. So
Yeah,
that
but
was my
you
biggest
grew
problem.
NTM from BAL, so and then your culture also was positive. Your Jadenstein was saying that is acid phosphorus. So you had all the reasons. You had a clinical diagnosis and a microbiological criteria to fulfill. So I think you were safe to start. But whatever has to be done has to
Dr.
be done.
Ankit.
So I think, yeah.
I don't think, again, as I said, I don't think we have a extremely good answer. Now, if you look at, adult data, then if you look at, the randomized controlled trials, which talks about using steroids versus antifungals, and some people treat ABPAs only with antifungals only.
Yeah.
I don't think we have pediatric trials, but we have adult data, and that especially refers to patients where steroids cannot be used, for example, diabetics. Okay, so I would look at that data again. I think I haven't, looked at that carefully because these situations are rare. But that is one option, that you can treat this ABPA only with an antifungal, and there are trials. So that can be one option. The other is that, the amount of steroids which you are giving in ABPA, the current regimes, it is not very high. So using it
0.5 to
for
1.
a short period of time might be okay. But these
Yeah,
are
but clinically he's done well 2 months without steroid. Like we didn't start this, we did only antifungal for 2 months and he's done better.
So that's what I'm
So
trying to say. You can read
Mhm.
up those
Yeah.
publications and see that how much therapy for voriconazole has been advocated and what has been the follow-up. That can be a good read. So because even the new ISHAM guidelines, if you read, they say that you can treat only with antifungals, but because these situations are a bit rare in pediatrics, we don't talk about it much. But if you have adult data and the child is doing good, and you can look at the radiology and the serum IGs for aspergillus, and if they are doing okay, then it's fair enough to not use steroids.
Sure. Dr. Bafna, you mentioned only 3 months for NTM might be sufficient, but
3
most
to
of the
6
places where
months.
I
3
read,
to 6
3 months
months.
is
So
not sufficient.
3 to 6
Yeah.
months. 3 to 6 months.
This is
You
one.
need to
so
serial.
I think if the problem is here comes. Okay, sorry, I think there was some technical issue here. Dr. Ankit, if I've disturbed you, please continue because I could not
Yeah.
make out whether you have stopped.
Problem is, treating the rest of the Kansas and all these things are easy, but abscesses is a nuisance.
Yeah.
If you read up any guideline for abscesses, it is at least for 9 months to a year or even longer.
Yeah.
And you have to prove that two cultures are negative, and it mandatorily involves one parenteral antibiotic. So what you have orally, you can use
Clarithromycin.
linezolid can be used orally, which is a good drug for abscesses, but you have to use some parenteral antibiotic. Now, the guidelines say that you should use imipenem or meropenem, putinolide, and do that. We have not been able to do that for any of our patients because it is next to impossible keeping them in the hospital. So what we resorted for two of our patients where we treated NTM, not in the context of CF. Otherwise, we had put them on alternate day or thrice a week amikacin and continued the oral drugs. You do that for 3-4 months. Keep track of their KFTs. Once the things are settled, you shift them to oral drugs and continue that at least for the next 9 months or so. But abscesses treatment is not very easy, especially in patients like this where they are already on so many drugs. Treating is not something very easy, and you don't know what are your targets, right? Because it is already a diseased lung. So there can be two ways to it. One, already diseased lung and you're not treating it, right? And you can cause more damage. But on the other hand, a complex patient where you don't know the things are progressing uh, because of an MRSA, or they're progressing because of ABPA, they're progressing only because of cystic fibrosis with age, they're progressing because it is a severe mutation, or they're progressing because of mycobacterium abscesses. So it is something which is difficult. I don't think there are any absolutely right answers there.
Sure.
But Ankit,
So I
we
think
already gave meropenem and linezolid to this child. That was my concern because we already treated him for 14 days with meropenem. He
Yeah,
was better,
but it has to
discharged.
be at least
That's the problem.
3 to 4
No,
months.
no, 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 no. That's what I'm trying to say. Then you end up treating partially. That's what. So this patient particularly had received meropenem for 14 days. Then he received linezolid. So then we never know whether he improved partially or he responded
So
partially. So
that's
that's
what
the
I'm
problem.
saying. It's quite difficult in this situation.
sure.
Yeah.
So our plan
I
was
think
to
Dr. Bharat, yes.
Yeah, so our plan, like you all discussed, and what Ankit said also, was using 6 months to up to 9 months of IV is going to be super difficult in this child because we're not getting IV lines at all. And considering the child was relatively improving, we have decided to go ahead with continuing antifungal. Like Ankit messaged, I was still not confident of using steroid, even though it's a low dose ABPA steroid. Since the child was doing well with just fungal only therapy, we still have continuing only fungal only therapy and not started him on oral steroid as yet. And we'll probably keep a close watch, monitoring him very closely. And I think if he lands up with the next flare up, then we can probably take a call on treating the NTM.
Difficult
So,
case,
uh,
difficult questions.
Difficult decision, yeah, to
So,
make.
what when we look at ABPA, the clinical presentation should be somebody who has predominantly V's, which is not responding to what you are treating, and that is when the steroids come in. And the role of antifungal is when, despite those steroids, he's not responding, and now you don't wish to bring that load of the fungus lower down. And with whatever antibiotics you give, beyond after a point, it is impossible to eliminate this fungus and bacteria altogether from the air where they stay. We can reduce their content, but we cannot completely take over. So it's all clinical. About that abscesses thing, I think if you for two things you have an answer, that the clinical, the child is not worsening, radiology is not worsening, then the treatment of abscesses is probably can wait. You can still monitor and wait, because if you had a clear answer that he is clinically deteriorating, radiology is worsening, and you have a ball growing this culture, then you would have definitely said we will treat. But 3 out of 2 questions you are saying it's not worsening, neither clinical nor radiological, then probably this thing we do not have a clear answer that we should treat here, at least in this given scenario.
Just one question for Ankit again is that we see the CT, we see that right middle lobe part which is collapsed is just not opening up. So this has been happening with the previous bronchs as well. So do we at some point consider that this is not going to open anymore?
Remove it.
It can happen. It can happen. So sometimes collapses don't open up, but
Yeah.
we don't have anything really good to offer them.
So,
We give
Dr.
them
Ankit, can we have
therapy.
the look? Can we have a look at the CT? Because if it is atelectobronchiectasis, it is not going to open up.
Yeah.
See, if it is a collapse because of some stuck mucus, you can open it up. But if it is atelectobronchiectasis, it's a it is a complication which is not going to go off. It's very rare for a bronchiectatic or atelectobronchiectatic part to improve. In literature shows that sometimes it may in children, but if it is atelectobronchiectasis, it is unlikely. But you can have a look at CT. It is showing dilated airways.
There was no
One thing
bronchiectasis,
more.
I think, at that middle loop.
Yeah, one thing more I would say is that if you have a persistent opacity and if you find that, the collapsed segment is not opening up, it might be a good idea to do a bronch again and look at the middle lobe bronchus. So there could be a situation when the middle lobe bronchus is narrowed and it is developing some stenosis. And if that is the picture, then you can consider, doing a balloon dilatation. Although in most situation, as Dr. Kamal said, it is going to be more like an atelectobronchiectasis where your bronchus would be fine, but it is the distal involvement which is leading to problems. Just one more thing I would say here, that if you look at the bronch video which you showed, it was showing a lot of mucus and slimy membrane sort of things. So is it not an associated aspergillosis or aspergillus tracheobronchitis which is there, or it is just an ABPA?
So the
They did
fungal
not grow,
cultures and the
actually.
fungal smears were negative.
Cultures, they are not grown.
Yeah, fungal culture was negative.
Cultures were negative.
Okay.
And I think it is just 4 weeks, so I think it will open. It
Yeah,
may
we
open.
should still
think,
wait.
Just
We'll
4
wait.
weeks. We'll have to wait. We'll have to wait.
Dr. Bharat, any specific question that you have? Because we are short of time, so we'll be winding
Yeah, sure,
up
sure.
now.
I think I conclude, and I think, as I said, this is the management we do right now for this case is to give fungal only, wait on the steroid, wait on the NTM. We'll watch him very closely clinically, and we'll update everyone how he does. Thanks a lot.
Interesting case.
Thank you so much. So the last words from me for the audience: if you have such a patient, the most important thing that one needs to do is a good chest physiotherapy and clearance, airway clearance therapy. Without that, nothing works. All this comes after that. So supplements, in this child, maybe if somebody had treated those with vitamin K, he would not have ended up with an intracranial bleed. So give supplements even when you are not very sure of the diagnosis. You suspect this, start supplements, start physiotherapy, and thereon later on you can add rest of the things. From my side, I think we have had a very nice discussion. Thank you, Dr. Pridarshini, Dr. Bharat, Dr. Ankit, and Bafna sir for the intellect inputs. And I now hand it over to Professor Dr. Rawat. Thank you so much, sir. Thank you from my side.
Thank you, Kamal sir. Thank you, Dr. Pidarshini, for an excellent case, excellently presented. Although it was a different presentation this time because we started with a case who we knew that the diagnosis and we tried to look after the complications of ABPA. And I think that the discussion between Dr. Bafna, Dr. Ankit Parak, they have given some very valuable insights in which how to tackle a child with complicated cystic fibrosis, because all these things chronic respiratory infection may be viral or mercurial diarrhea, NTMs and ABPA, they all are a part of a child-based cystic fibrosis. And I think methodical workup, methodical thought process, working up, I think it'll give good dividends. So I think the discussion has been really good, and I hope that all the delegates who were on board, they must have benefited how to work up a complex case of cystic fibrosis. I think Dr. Joshi is there and he wants to make some
Yeah.
point. Yes, please.
So, I'm sorry I joined a little late, but then it was a very interesting case. Just one query. I mean, like, as a rule goes, we have all been learning from our undergraduate days that any abscess is there, it has to be drained for a complete recovery. Is there any specific reason that we don't attempt drainage here? Just because it is the inaccessibility of the area, or it is difficult to perform? What exactly is the reason why we attempt drainage here?
So I think your audio was not very clear to me, at least. Dr. Ankit, could you
Yeah.
get it?
You want me to repeat? Am I audible now?
No, I've got your question. So it is
Yeah,
a
yeah.
Mycobacterium abscessus bacteria which is there. And there is no abscess. There is no lung abscess which can be drained.
Okay.
So it is a non-tubercular mycobacteria which is colonizing or leading to pulmonary disease. That is the question. Is it just a colonizer or a pulmonary disease? But there is no lung abscess which can be drained.
But then we mentioned about this having a possible polymicrobial origin. So would
Yes,
there be a possibility that you can have a bacterial component also here?
there is a bacterial component. This grew MRSA.
MRSA.
But yeah, so particularly in such a case, would that be the reason that you took a little longer for the response to come?
Uh, the MRSA was not treated. I think that is the reason why this child was running fever, and that happens in patients with cystic fibrosis.
So thank you very much, and we'll meet again next month, last Monday, with a fresh case. Till that time, goodbye and good night from IPNRC. Bye bye. Thank you very much.
Thank you,
Thank
Kamal.
you.
Thank you, Dr. Rawat
Yes,
and
good night,
Ankit
everyone.
and Bharat. Thank you.